Yeah, hello and welcome to the Tulip Airway channel. This is video number 27. In this video we're going to talk about how to pick the right strategy for a difficult airway. Things can become very stressful very quickly, so looking at the new methodologies and keeping up to date as to what can be done I think is important. Now, we talked about simplicity in the headline, but what do you mean by simple? I think, in times of great stress that you need something that's fast, effective, efficient, works every time, you can rely on it. Problem with laryngeal masks and eye gels, etc., they can leak in and around what, 20-25 centimeters of water, something like that. Intubation is not always possible. Gedelan mask, you have to generate quite large pressures with, that's gastric insufflation is a problem. So ideally, I think in an ideal world, you'd need something that produces a high ventilation pressure if you really need it. No leak, and you can do what you want to do, what you need to do. So what about versatility? Well, this is the thing. Why have we got so many airways? I'll go into that in a moment. But basically, if you're talking about something that's versatile, you really would like something that works when the patient is semi-conscious, fully unconscious. You can use it for starved elective. You can use it for induction recovery. Something that ideally works in every plane and every stage of anesthesia. Now, talking about the right strategy, I think it's important that we look at how easy a tulip can be, right? What that means is default position, instant reaction, immediate response, and compare it to what else is available and why. I'll give you the evidence of why I'm suggesting this, but people tend to stick to things, and this is a psychological block, particularly at times of crisis. So people can get into overly complex situations trying to do something important, and what you need to do is chuck away everything you really don't need and move into something that really helps you at a time of extreme trouble. So, and the psychology of this is, I've written something about this, but basically, probably the most quoted psychological principle on earth is probably fight or flight. Would you agree? I mean, it's probably like the psychological principle everybody's heard, but it's in fact wrong, because it isn't fight or flight, it's fight, flight, or freeze. And now that I say that, you're like, yeah, of course it is. Rabbits, deer, everything does that, including humans and anaesthetists. So, the freeze response is usually omitted from any discussion, but it's easily the most common. So, when you're facing something that's a real danger to the person, to your patient, if it's a life-threatening situation, if it's a difficult airway, time is just the most important commodity, and what do you do then? Do you go for something you've already tried? Do you try the complicated kit? What do you do? What is it that makes that difference? And we're going to have to break that down into, what strategy should you use? What's the simplest, most effective, most versatile? And sometimes, features are considered, great, but you know what? Something that's simple and works is probably the best thing. Overly complex, overly clever, that's 100% wrong, isn't it, when time's ticking by? And it's like the strategy itself, the decision-making process, the numbers of steps. I mean, in the Difficult Airways Society protocol, there's, A, B, C. Well, we can simplify that to it, can't intubate, can't oxygenate, move straight over to step 2, and you're pretty much done. So, do we need to streamline airway management so that, you can get to straight effectiveness with no complications faster? So just imagine two scenarios, okay? One's a single streamlined protocol and the other one's multifunctional, right? The simple methodology is always going to be the right strategy in this between these two, all right? So a simple, effective, rather than complicated, multi-layer, multi-step procedure. So so we're going to come back to that question I said, we've got so many different airway advisors. Why is that? If an airway worked, you'd have one, wouldn't you? Right? Yeah, so we're going to come back to this problem. Why do we have so many airways? It's because no one airway does them all. If one airway worked, we just use one. So if you had, if a Gadella mask was hands-free, directly connectable, you could use it for starved elective anesthesia without holding it, you wouldn't need an iGel or an MA. Yeah, and just as equally, if a laryngeal mask or an iGel supraglottic airway could be tolerated in semi-conscious planes, right? So you wouldn't need a Gadella mask either, would you? So the that is what a tulip is. It is the device that you can use in all planes and stages of anesthesia. It is directly connectable, it is hands-free, but it's also tolerable in a semi-conscious condition. So that is why a tulip can replace a Gadell mask, a laryngeal mask, an iGel. All right, so it is this broad range. It's this ability of all. So the analysis paralysis. Okay, too many options available at the moment, in my humble opinion. There's basically there's a plan A, there's plan B, there's plan C, and as you work through it, the patient just desaturates, right? And those delays add up to something that could be fatal. So, forgive me. Is it safer to master a single tool that you know works all the time, or do you want to be going through 3 different steps and getting more heated? What are you going to do when the SATs drop? Okay, so standardized primary approach. Okay, that means basically finding a single success setup that works every time. Okay, like for example, one thing I do is if I'm expecting a dangerous situation, if it's a road traffic accident and I'm about to intubate, I will use a flippy tip laryngoscope with a short handle, and I will always put the bougie through the ET tube before I start, because this is likely not to be easy. I'll go flippy tip short handle, that's easy, and then basically I will use an ET tube with a bougie preloaded. So basically I've already covered the options. There's no waiting, there's no second try, there's no deterioration. I'm getting in, that's it, end of story. But again, this is exactly where the tulip comes in. You do it first time, you get it right, it happens, it works, it's fine. There's no plan B, there's no plan C, it's plan A, plan A, and plan A. Now, the reason we suggest this is because basically we know it works, and basically we've got the evidence to prove it. So happily this isn't me just shooting my mouth off. There's plenty of evidence now, several life-saving cases where plan A, plan B, plan C didn't work, Tulip did. So what that would do is basically default position to hang on, this is not going right, I need to sort it now. And this is kind of reusing, practicing, trying. Tulip will enforce that muscle memory. When things go really wrong, reach for a tulip. You may think I'm exaggerating the claim, but I'm not, and basically there's evidence to prove it. And again, this is, should be a standardized approach. Okay, and simplicity first works. We know it, particularly in chaos. And basically this first pass, 100% successful first time, is particularly useful in places like pre-hospital care. Tulip was designed for use in your home. So, but one other side is you can't be too skilled on the other stuff, bronchoscopy, intubation, all this stuff. But point is that you don't have to practice at times of emergency, no, do you? Right, so you can do that at other times, but basically you're still going to need a diverse set of skills, and Tulip is basically going to add to your toolbox. I'm not expecting you to throw laryngeal masks away, I'm not expecting you to throw iGels away or Goodell's and masks. It's like when I buy an electric screwdriver, I don't throw my screwdriver set out. The electric screwdriver goes in with the rest of the set. So a Tulip is basically there as an additional tool for you to use. And I think this is really important. It's like, if you don't like Tulip, for God's sake, don't use it. It's probably not safe in your hands. So let's talk about this multi-plan thing. All right. So, okay, here's a difficult Airway Society guidelines for a failed intubation. All right. So We've checked everything out. Bottom right hand corner, equipment check, functioning waveform, pre-O2, etc. Okay. Now what happens here is basically you fail to intubate, right? You try all the normal stuff, you remove cricoid pressure, you try the bougies, which my ET tubes already have. You basically optimize position, but I did that in advance, so none of this stuff particularly helps. Now the video laryngoscope, yeah, maybe, but I prefer short handle flippy tip. Okay. Now basically the point is they say go supraglottic airway device. Okay. This is where we are going to differ, but let's go through the recommendations as they are. What then happens is if you're unsuccessful, you change size, try doing an iGel instead of an LMA or vice versa. Basically, if you fail, you get a face mask. Okay, now things are now starting to get not great because you spent some time doing those two things. Now, basically, what we're trying to do is ventilate. Now, sometimes you can't ventilate with a Gedeon mask. I've been there. I've seen it happen. Okay, notice Plan D. Plan D is not good. Okay, so you're going cricothyroidotomy now. How many minutes have ticked by while you did that? 2, 3? Okay, this is what I hope you never need to do. And if you use a Tulip, you will not need to do this. That's a hell of a claim. If you don't believe me, basically the evidence is there. If you want to contact me directly, I'll explain. So anyway, so that's when things go really wrong. Okay, so it's basically intubation, maximum 3 attempts, supraglottics, followed by face mask, followed by cricode. Okay, as I said, you need to basically keep the versatile toolkit. You may need to use all of that, right? Such as, the supraglottic airways as a bridge, the surgical neck access, the fiber optics. But what is the trigger that moves one to the other? That varies a lot. How long do you spend with the Gedeon mask? How long do you spend with the supraglottic airway? Okay, so this can vary hugely. It can be 2 minutes or 10 minutes from A to C. So, pace setting. Okay, there's got to be a time on this. There's got to be a clock on this. What is it, 60 seconds per step? This is where I think this is important. I think the outline, how long do you spend on step 1, on 2, etc. But simplicity should govern that first 60 seconds, right? Effectiveness, simplicity. Then I think you need to be versatile about what you need to do next because you don't know what the cause is. If it's like, for example, you've got like an oral tumor or something like that, God knows. But you need to have some flexibility, which is why you need the other skills. But what you need to do is build a personal algorithm. If you don't like Tulip, don't use it. Basically, my point is that, if you do, you probably will. And if you don't, tell me why. But the point is that there's simply a case of you have to be comfortable in your own skin. You have to be comfortable in your own shoes. You have to be comfortable with what you're about to do in a court of law. So this is where we differ, okay? Basically, plan A, tracheal intubation, top left up here, okay? But then what happens is you don't go supraglottic. Plan B is Tulip. And why? Because it doesn't fail. There is no plan C. You don't need a Gedeon mask. Tulip works better than a Gedeon mask. So this is what a Tulip looks like. All right, so it's got a self-retentive right angle bend. It's got an external connector that you can tie to. There's a headband version, but what you've got is an oropharyngeal airway that completely occludes, doesn't leak, ventilates higher than anything you've come across. So you could comfortably exceed 40 centimeters of water if you have to in times of emergency, and it won't leak. That's what they look like in real life. Top left, you can see there's a version for Gedeon mask replacement. The ones on the top right in the headbands, they're more for theatres, just long-term stability, slightly longer bite blocks. So when you compare a Tulip and a Gedeon, right, both basically the Tulip is hands-free and directly connectable. So it's that flexibility that we were looking for at the beginning, And we also wanted the versatility, but we also wanted high success rates. And Tulip has been shown to be 100% successful first time. You're going to get higher tidal volumes. Because it's directly connected, you get significantly higher oxygenation with less ventilation pressure because it has such a wide tube. So regurgitation risk actually reduces. Now this this is why I'm making this video. This is a real life example of why simplifying the difficult airway management algorithm is a benefit at plan B. If you fail on intubation, reach for a tulip. All right, why? Because you will succeed at a higher percentage of the time. And here's an example. This is a presentation made by a Polish doctor who, forgive me, Turkish doctor who basically presented at Euro Anaesthesia last year. And it is a can't intubate, can't oxygenate scenario. And the day was saved by a tulip. And as you can see in the pictures, there's an orange tulip being introduced.
A size 2 green tulip is equivalent to a green Goodell. For a mannequin, lube the device well. Put the cuff in the mouth first. With the thumb, push down and straighten the tube. Push straight in. Inflate to 50 mils before ventilating. Hold your thumb on the syringe before letting go.
So the immediate impact is that patient stabilizes, right? If you use a tulip, immediate stabilization. This has happened numerous times. It's happened in front of me. Basically, you get immediate airway control and all the physiological benefits. Let's talk about neurology. So basically, these are life-saving experiences. They're in video too. Recommend you watch that. And basically, just to put it into context, Plan A, B, C, Difficult Airway Society recommendations did not work. Tulip comes in, saves the day. Now, these have been published, they're presented, serious places, Euro Anesthesia, World Military Congress, it's proper places. So basically, this is really about you future-proofing your airway skills, because skills don't stand still. When new stuff is released and it's really good, you use it. Like, okay, you didn't use an iPhone, but you do now. It took you a little while to understand about it. Okay, it's all great. It's all in one place. Well, Tulip is like the iPhone of anesthesia. It's all in one place now. I recommend you try it because, look, me talking isn't what's going to persuade you. It's how does it work in your hands? Are you comfortable? Okay, you've got a lot of evidence now. All you've got to do is try it. Once you do, no coming back. If you want to read about it, the publications, the presentations, the independent trials, international trials, all p-values are less than 0.005. All right, so that means it should really be applied to everybody ethically. So, this is, providing you with a slightly more definitive checklist for what you should be perhaps thinking about for your patients in your environment, because Tulip is even more useful in remote healthcare situations. So that's what a tulip looks like. That's a Tulip Airway, and I'll see you next time.